And now we move on to the next topic of topical therapy of atomic dermatitis by the learned Dr. Rajib Malakar, clinical tutor, Department of Pediatric Dermatology at the Institute of Child Health, Kolkata. Over to you, sir.
Good morning. I will be starting the last session of today with an overview of topical therapy in atopic dermatitis. But before I start, I must express my sincere thanks to Mr. Pathopal and Paulson's Group of Industries for giving me this opportunity, and must acknowledge Dr. Sandipandhar and Dr. Raghubir Banerjee, who has been my teachers, mentors, and guides, and has taught me whatever pediatric dermatology I know today. So, let us start with our topic. Going through the list of topics to be discussed, you must be a little bit surprised that only topical therapy in atopic dermatitis has been kept. There has been no mention of systemic therapies of atopic dermatitis. Why is this? Why topical therapy is more important? There are certain facts for you. Number one, majority of the Indian children with atopic dermatitis have mild to moderate disease, which will respond adequately to topical therapy. Number two, systemic therapies are generally used for a short duration to control flares, which are then maintained by topical therapy. And very small percentage of Indian children with atopic dermatitis need long-term rotational systemic therapy. So, as a pediatrician, the most likely when a child of atopic dermatitis comes to you, the knowledge of topical therapy will be adequate for controlling his or her problem. Before we delve into the strategies and individual elements of topical therapy, it will be ideal if we know what we are dealing with. This will give us a framework to understand the rationale behind these strategies and individual elements of topical therapy. When we talk of atopic dermatitis, these are what we are dealing with. This dilapidated wall shows the defect in barrier, represents the defective barrier. This dry desert reflects the dryness of skin and its inability to hold on to moisture. And these funny soldiers represent the weak and defective epithelial immune functions. So these three are the primary problem in a child with atopic dermatitis from a dermatologist point of view. Along with this, there are certain basic facts about this disease which will impact our strategies. Number one, there is absolutely no cure, like chronic urticaria. And what we try is to strive to attain and maintain control of the disease so as to improve the quality of life of the child by reducing the severity and frequency of attacks, by controlling the activity of the disease. So with this, let us consider about the basic strategy of the management in atopic dermatitis. Now, before I delve into this, you must understand therapy does not include only medications. A very large part of it are lifestyle modifications and important general considerations which are the cornerstones and will determine the success of the topical agents that we use. So the main pillars of management are, there are three pillars of management in atopic dermatitis. Number one, avoidance of triggers. We'll delve into the details of each. Number two, proper skin care. And number three, proactive treatment. These three are the most important or the main components of the management of atopic dermatitis, which will provide long-term clinical relief to the child. So, individually approaching each of them, in our part of the world, the most important triggers are what you should be aware of as a pediatrician, as a first contact, are the sweat, dust, and the insect bite. The common Western concept was basically that the atopic dermatitis tend to flare in dry climate. But in our experience, sweaty weather or hot and humid environment makes controlling the disease extremely difficult, and majority of the flares of atopic dermatitis, not only that, but also xerotic skin condition tends to occur in hot and humid environment. So sweat is a very important component which can trigger not only flare but also defy or induce apparent treatment resistance. Dust is a common element which can induce, but unlike sweat, it is not ubiquitous in our children environment, which might cause the problem. Insect bite, on the other hand, is an important element, and many of the patients come to you with papular urticaria. Majority of them may have full-blown atopic dermatitis, may not have full-blown atopic dermatitis, but may have atopic diathesis only. That means minor manifestations of the disease. So if you can eliminate or at least reduce exposure of the child to these three elements, that will significantly improve the quality of life and will significantly reduce the necessity of treatment. Along in the same vein, due to the barrier dysfunction, there is also an increased chance of contact sensitization. So this can be avoided by number one, implementing, repairing the barrier defect. Treating the disease condition itself will help, but apart from that, using of proper moisturizer as an accelerate to accelerate the barrier repair has been quite elaborately discussed by Dr. Raghuveer Banerjee. Apart from that, there are some simple common tips. There are many more, but these are very common tips that you can advise your parents. Like, wash the new clothes because they tend to contain formaldehyde, formalin. Rinse clothes properly after washing with detergent, so the detergents do not stay over. And lastly, avoid adding disinfectants. If you are inclined to use disinfectants or antiseptics to clothes, use them before using detergent, not after. So these are certain simple steps. Like these, there are multiple other steps that can be thought of when you are advising your patients in certain lifestyle modifications. Number two, the second pillar of the proper skin care. This involves regular and liberal use of moisturizers. I'll not delve into it as it has been extensively discussed so far, but this is a vital, important part. Number two, even though this is due to an irritant like sweat, there are simple measures which I have included into the skin care part. Make the child wear pure cotton, loose, full sleeve, soft, aerated dress. This, in our condition, for example, in the hot and humid environment of Kolkata and the surrounding area, this is an ideal dress code, excepting when formal dress code has to be used, like school uniform, to protect the skin, keep the skin aerated, and also avoidance of insect bites. Lastly, in case of recurrent bacterial infection, which is very commonly seen in atopic dermatitis cases, you can try mupirocin prophylaxis. This will help in avoiding both flares of infection, flares of atopic dermatitis, and recurrent pyoderma. So put it all in this. This is simply a solution. A child with the classical dress code that I have been talking of, which will definitely give her significant improvement in quality of life. Now coming to the last point of the management pillars, this photograph clearly explains the philosophy behind the proactive therapy. Even though there is apparent clinical remission, there is significant inflammation persisting underneath. So, the slight suboptimum levels of irritation might induce flare. So, initially, earlier days, there was the strategy of reactive management where only flares were treated and then treatment was completely stopped in between when there was apparent clinical remission. But as you can see, even though there is significant reduction in flare or the disease becomes clinically, the skin becomes clinically normal, there is subclinical inflammation remaining. And that can stay for a significant long period of time. So continuous use of medication in a lower dose, in a less frequent manner might be a good idea to control that flare in order, control that subclinical inflammation in order to limit the precipitation of flares. So this has been clearly mentioned in Journal of American Academy of Dermatology in 2013, where they have specifically mentioned proactive treatment in patients of atopic dermatitis may improve the number and severity of the disease flares. So this is again an example of continuous use of topical steroids, combination of topical steroid and TCI, topical calcineurin inhibitors, where topical steroids are gradually reduced within first 2 weeks, then used in a much less frequency and stopped completely after 4 weeks, whereas topical calcineurin inhibitors are being continued continually for 6 weeks, then reduced gradually over a period of 12 weeks. This is a typical classical example of long-term proactive therapy even after apparent clinical remission. But this proactive therapy can be continued over much longer duration. So with this, we'll end the strategy part of the treatment by giving you this therapeutic step ladder in atopic dermatitis, where you can see, as I have mentioned clearly, the systemic therapy part takes only a very small area of treatment in atopic dermatitis. Only recalcitrant severe atopic dermatitis are to be controlled by systemic therapy. Whereas the basic treatment, we do not use any medication at all, only moisturizers and the skincare regimen, avoidance of irritants. The mild to moderate disease is controlled by low to mid potency topical steroids and TCI. The moderate disease is controlled by mid to high potency TCS and TCI. And only severe condition is treated with systemic therapy. Now let us move on to the individual elements of topical therapy that we are going to talk about. The commonest drug that is being used, that you are all very well acquainted with in the treatment of atopic dermatitis, is topical steroid. There are certain tips that I like to go over when you are using steroid in infants. and children. Number one, you remember infants have an increased skin surface area and a weight ratio. So the degree or the amount of systemic absorption as compared to body surface area to the mass ratio is higher, which is combined with relatively thin skin, specifically in premature infants, which will lead to a much higher systemic level of steroids, which can cause HP axis suppression and even Cushingoid features. To bear this in mind. Number two, special care while using over nappy areas. Two reasons. Number one, because of the moist character of the area, there will be increased absorption. And number two, because of the occlusive character of this area, the low potent steroids will behave as a much higher potent steroid, producing the adverse effects of those higher potent steroids. So choose carefully what type of steroid you want to use in the occlusive areas. So in general, try to restrict your choice to low to medium potency steroid. These are preferred, and prolonged use should be avoided. As in the diagram that I have shown, combination of TCI and TCS are to be continued, where TCS is to be withdrawn as soon as possible after significant clinical remission is attained, and remission is to be maintained with non-steroidal alternates. And intermittent therapy is necessary. Intermittent therapy is preferred. For example, there is a form of therapy called sandwich therapy, where weekend topical steroid is combined with weekday TCI. This can be used for a long duration. Now, use of topical corticosteroids in atopic dermatitis. Any special points that I want to mention in regard of this use? No problem, not needed. The lowest potency topical corticosteroids likely to be effective may be considered initially, generally class 3 and 4. You can and should consider high potency TCS if certain initial preconditions are met. Number one, if the pruritus is intense. Number two, if the lesions are overtly inflamed or lichenified, because low potency steroid will not work specifically in thick or lichenified areas. And to improve compliance, because lower potency steroid will take some longer time to produce significant clinical remission that may not be to the satisfaction of the patient. So you must choose whether you can use a higher potent short duration therapy to induce remission, followed by rather fast stepping down or tapering in the potency ladder. Or you can use a low potency steroid for a longer duration. I myself prefer to use a comparatively higher potent steroid for a shorter duration to induce certain degree of improvement, followed by comparatively rapid tapering down the ladder of potency. This is for your information. This is a quite informative article or review article written by Dr. Tutor about topical therapy in atopic dermatitis in Indian Journal of Pediatric Dermatology in 2013, where he has typically described the utility, the pros and cons of different potency and the classes of topical steroids. This might help you as a guide when you are choosing or considering topical steroid for your patient of atopic dermatitis. Now, our discussion will not be complete unless we talk a little bit about a very misused and misunderstood combination, that antibacterial steroid combination. First and foremost, routine use of this combination is not recommended in cases of atopic dermatitis. Number two, It is not to be used when there is definitive overt signs of infection where systemic therapy should be used or systemic antibiotics should be given. It is only to be used in sudden flares of small areas of dermatitis, and that too for a very short duration. I'll show you a classical example. This retroauricular fissure are a classical example where this topical steroid antibiotic combination works best. Moving on to the next very important element of topical therapy, the TCI or the topical tacrolimus, which has been approved by US FDA by the year 2000, and it has been found to be effective in children and in adults with moderate to severity. Both strengths have been found to be effective. From practical key point, it is to be applied twice daily. Both 0.03 and 0.1% formulation are used to be adult, 0.03 formulation to be used in children, though we have contrary evidence. Treatment has to be continued for 4 weeks after subsidence of eczema, as demonstrated by the previous combination treatment slide that I have shown you, and then as a maintenance therapy, at least for 12 weeks, maybe more. And it is effective and safe on face and flexors. How long can you use that? Twice daily on all affected areas in children and adults for up to 2 to 3 years. Long term as a maintenance therapy, it can be used continually or interrupted. This is again an article by Dr. Tutor and Dr. Banerjee where they have used at that time available tacrolimus in 2004, the Protopic, in 15 children aged 3 to 15 years, and they have found significant reduction in severity scores without significant adverse effects. Mind you, they have used 0.1%, not the 0.03% as recommended. So as early as 2004, they have been used 0.1% off level in Indian population without significant adverse effect, and they have published it. So before moving on to the next, the apparent failures of treatment, when a patient comes to you and says the topical therapy is not responding, before concluding the topical therapy will not work and switching to systemic therapy, please consider this point. Number 1, non-compliance. Number 2, under-treatment. Number 3, sudden reduction of potency of steroid. Number 4, sudden stoppage of topical steroids. These may be the reason for apparent flare and apparent non-response to therapy. After and only after you have considered this point, you can label the patient or consider the patient for systemic therapy. Of the newer topical therapies that has been considered, the most important drug that I should talk about is crisaborole, which has been licensed by FDA in 2016. The other drugs which are in phase 3 trial are the JAK inhibitor and aryl hydrocarbon receptor modulator. Crisaborole is a phosphodiesterase 4 inhibitor, and it has been found to be effective. Almost 50% of the people where it has been prescribed, they show significant improvement in investor static global assessment. It is yet to be approved by DCGI. And before conclusion, there are certain points that I'd like to mention. This is a publication on the guidelines of care of management of atopic dermatitis with topical therapy, published in Journal of American Academy of Dermatology in January 2023, where I'll only demonstrate the recommendations which have strength of A and level 1 evidence. Use of moisturizers, this was the first one. Use of topical corticosteroid. Need for considering the side effect with use, that is why you need to choose the steroid very carefully. Use of TCI is a steroid sparing agent. Off-level use of TCI in those below 2 years of age. and proactive use of TCI for maintenance, and against routine use of topical anti-staphylococcal treatment. Thank you for your patient hearing.